Assalamu alaikum, everyone. Welcome to the other session of ALL case presentations. Sorry, the case presentations on acute leukemias and myeloid disorders. The first case will be presented by a colleague, Dr. Amrullah, the colleague and friend. He's a consultant from Tawam Hospital, and he wanted his introduction to be very short. So, Dr. Amrullah, I hope I was not that long, and the mic is used for the case presentation.
Okay. So, good evening, ladies and gentlemen. Thank you for a nice introduction and nice start. In the next 5 minutes, actually, I will present AML first, actually. First, my AML series of cases and what is challenges in 2022 and how to move to less aggressive therapy. So this is a young male, actually, who has no comorbid, who has 1 month history of B symptom. Then he was found in some park, because of low hemoglobin, and then he led to hospital. They found pancytopenia, then referred to Tama Hospital about 2 years ago. And we found here, you can see the graph, all the counts were down and LDH was high. And so we did bone marrow. It is typical CD33 AML, and cytogenetics was normal, FLT3 negative. So what we do, as you know, resources, NCCN and expert online. So the treatment, everybody knows, induction is 3+7. So, and plus he was also CD33 positive. Now the standard is plus gemtuzumab. So in this case, we started actually 3+7. We don't have gemtuzumab available. So all the PIC line inserted 3+7 started. But unfortunately, this patient developed on day 20 colitis and septicemia. So and we found he has staphyllitis actually based on the CT scan. And more important thing, on day 24, we found the WBC count went up and blast cell also, came up. It means there was problem, and LDH also went up, you can see. So on day 24, we did bone marrow and unfortunately showed about 60% blast cell. So it means refractory AML. Now the question is, if refractory AML, so we have A, B, C, D, 4 option. A option is re-induce. We cannot do it because already patient is suffering from staphyllitis. And other option is targeted therapy. We don't have any target so far report. And third is aggressive therapy, and fourth is less aggressive therapy. So we actually choose D, and even you put sources to solve the problem, expert online, they also give venetoclax plus methylating agent followed by allogeneic transplant because the patient is young. So fortunately, he responded after first cycle, and after first cycle, bone marrow revealed complete remission. So we continue 4 cycle till patient went for transplant, finding, matching, and everything done. He went allogeneic transplant, and the good thing is over the 2 years, you can see the graph. Now he is in complete remission. So he's a young patient. The idea is to show you V square plus allogeneic transplant. So same idea actually we use other patient who had AML 3+7 consolidation successful story. Then again he relapsed, and again here actually we gave Vedaza, but after 6 months again blast cells came. So here you actually made venetoclax plus Vedaza. Then again he went for allogeneic transplant, and he's 2 years again his story is in complete remission. So similar story. Now third patient, again young male who was admitted with abdomen pain actually and small bowel obstruction. All the labs are fine, CBC is fine, everything is fine. So he underwent surgery, laparoscopy, and the thing is they found positive for LCA, negative for cytokine. So they were thinking high grade lymphoma, but they found luckily positive without losing. MPO was positive. So usually, people miss the diagnosis, but our pathologists, they found the diagnosis, and we did bone marrow was negative. So this is the question, does the presence of EM involvement confirm the worst prognosis than normal AML? Number 1. Number 2, should chemotherapy be initiated patient with isolated AMS? So anyway, we started 3+7 chemotherapy recently. This patient is admitted. So similar one case is middle-aged lady, multiple comorbids, diabetes, chronic kidney disease, echo performances too, and she was with a pancytopenia, again diagnosis AML, and I wanted to show you, how the less aggressive therapy actually work. Here also we use azacitidine and venetoclax combination, and you can appreciate the disease bent up after 2 cycles, and now he's done almost 1 year. He's on treatment. She's on treatment. Sorry. So this is the last case, 68-year male who was de novo AML, again comorbidities. So this patient is also diagnosed as AML, and what is the appropriate treatment we use in this patient also is azacitidine and venetoclax, and you can appreciate after 1 year he is fine also. So the idea is actually what I wanted to show you here. Actually, my question was, again, you have listened just now, Professor Savannah. He also presented the data beyond the 3+7. My question is same. The data is now, we have data. V square 76% is complete remission. So the idea is to give the therapy. Then, if patient is really candidate for transplant, like mother of all, we use in 2 patients you have seen, they went in complete remission. So this is my question, and this is my presentation to show you our experience. Thank you very much.
Thank you very much, Dr. Amarlal, for your very nice cases and compelling. Unfortunately, you had very limited time, so you had to go fast. So we apologize for that.